Good evening, everyone. We will now start with the webinar. I would like to thank Lupin Oncology for supporting this meeting. I'm requesting Dr. Shona Nag to request all the speakers and participants.
To hot topics in breast cancer, and today the focus is on triple negative breast cancer. These are basically themes and topics which have been taken from the recently held ESMO Breast Conference, which was a virtual meeting this year. So may I invite the first speaker, Dr. Meenu Walia. She's going to talk to us on the pathology and clinical management of rare breast cancer histological subtypes. Dr. Walia is a senior consultant medical oncologist at the Max Super Specialty Hospital in Delhi.
Hi, Dr. Meenu, hello?
Yeah.
Yeah, yes, ma'am.
Can you hear me now?
Yes, we can hear you, ma'am.
Yeah, thanks, Dr. Shona. Thanks, the organizer, for the opportunity. And without much delay, I think I'll start straight with the topic. rare breast cancer, the histological subtypes. That is what was the topic given to me. That was presented in ESMO this year to talk about the various subtypes and their management. So coming to breast cancer, in the WHO classification of 2019, the breast tumors are further subdivided into at least 21 different histological subtypes. And if we look at this profile, although it is the ductal carcinoma which makes the majority, about approximately 70 to 75%, a small minority being made by lobular carcinoma, approximately 10 to 15% are the ones which we know as the rare histologies or the rare subtypes. And how these special subtypes are classified? Because the same histological pattern should be seen in more than 90% of the tumor, and they seem to have a specific biomarker profile. If the percentage is so small, then what's the big deal in identifying them? We still need to know them because they seem to have not only a distinct biomarker profile, they seem to have a distinct prognosis, and the pathology seems to be much more different, and the response to treatment also in this subtype is quite different than the usual types. Coming to the next slide. What is more important is that before diagnosing that it is a rare subtype, we need to have a centralized pathological review. In as many as approximately 20% of the cases, the subtype is generally not confirmed. After the second pathological review, a histological grading as is required should be done in all the cases along with ER/PR HER2/neu. Molecular testing, generally not done, may be required as part of a clinical trial. Pathological review, as already mentioned, should always be done. And in case there is a discordance between the various receptors, then probably the restaining should be done if it is not consistent with the pathology report. For the sake of simplicity, all these subtypes are majorly divided into three major groups. One, where the neuroendocrine differentiation is seen. A broader group will be a ER positive group and a ER negative group, and plus apart from the non-epithelial, you have the phylloids group which is seen. Epithelial tumors, they are basically divided into ER positive and ER negative. And for further simplification, they are subdivided into those with excellent prognosis, with those with an intermediate prognosis and bad prognosis. We have three main subgroups which have got an excellent prognosis: the tubular, the cribriform, and the papillary ones. And these are the tumors where you find that although in a small percentage of patients, generally they are ER/PR positive. This is mainly a ER subgroup. PR is also positive, and HER2/neu negative. And overall 5-year disease-free survival as well as overall survival is quite good. And these are the patients who do quite well with adjuvant endocrine therapy only. Chemotherapy in an adjuvant setting is not recommended, looking at a very good, excellent prognosis in this subgroup of patient. The same goes for cribriform carcinoma, which accounts for less than 0.5% of all breast cancers. Again, strongly ER/PR positive, low-grade tumors, HER2/neu negative, with excellent overall survival. And there has been some studies where no deaths have been found because of the disease per se, and as long in patients who were followed for up to 15 years. And most of these cases are invariably N0 to present with. Nodal involvement is very less. And again, in this subgroup, because of the excellent prognosis, adjuvant chemotherapy is generally not recommended. Papillary, another group with ER positive tumors and an excellent prognosis, low-grade tumors. Lymph node and distant metastases are very, very rare. Majority of these tumors are encapsulated and they are generally treated as a tumor in situ. The invasive forms are generally treated as the other common, not of no specific significance type of the IDC type. Most of these patients again do not require adjuvant chemotherapy. However, What is to be noted is that it is a papillary type, because the minute our pathologists describe it as micropapillary type, then the prognosis changes. Now we come to something, mucinous carcinoma. I think not so rare. It is to the tune of 2.6% of all breast cancers, and I think most of us would have seen one or two odd cases of mucinous carcinoma in our practice. Definitely has a good prognosis, not as good as the tubular and the cribriform one, but still a relatively good prognosis with a 5-year disease-free survival to the tune of 90%. And generally, endocrine therapy should be the way to go. Adjuvant chemotherapy is only considered if it is a grade 3 disease, which generally it is not, or if it is a micropapillary pattern, or it is a lymph node positive disease, and sometimes it may be HER2/neu positive. That is approximately 10 to 20% of the cases where probably then adjuvant chemotherapy and targeted therapy will be warranted. Going to further subtype, lobular carcinoma. So lobular carcinoma, we generally see two histopathologies. There is a classical lobular carcinoma and there is a pleomorphic lobular carcinoma. The classical lobular carcinoma is the one which we see more commonly and has got a good prognosis, relatively superior prognosis. But it is the pleomorphic one which seems to have a poor prognosis. So lobular carcinoma, generally a luminal A or a luminal B subtype on molecular profiling, 10-year overall survival to the tune of approximately 68 to 70%. What is to be noted, we would have been seeing in a clinical practice also, that this is the subgroup where late recurrences after many years, after 20 years, after 30 years are also known to be there. And they seem to have a very different pattern of metastasis. The serosa, the cavity seems to be, the serosa, the lining seems to be very commonly involved in this subgroup. Generally, they are not chemo responsive. However, with the present guidelines, we do still treat them with chemotherapy if the disease burden is very high or if it is a nodal positive disease. Going further, the pleomorphic variant, 1 to 5% of the lobular carcinoma may actually be a pleomorphic lobular carcinoma. And in approximately 1/4 of these are HER2/neu positive, and it generally is a grade 3 tumor. Rather than the classical lobular, which is generally a grade 1, grade 2 tumor, the pleomorphic one is generally a grade 3 variant, and molecular signature is that of a molecular apocrine tumor. This is the one which have a very high recurrence rate and overall survival. If we compare with the classical lobular, it is less than 50%, the 10-year overall survival. And these are the ones who generally do not have that good a prognosis. And yes, chemotherapy is almost always indicated in a pleomorphic lobular carcinoma, especially in the node positive disease. So coming to the last one among the ER positive subtypes, the micropapillary variant, which is notorious for its bad prognosis. So I would want people to note that if it's a papillary variant, then it is a good prognosis. But wherever we come across a micropapillary variant, the papillary ones generally have a grade 1, grade 2 disease, and the micropapillary has a more aggressive grade. And again, in as many as 50% of these tumors, they are HER2/neu positive. The papillary one is generally localized disease and HER2/neu negative. This is generally locally advanced in presentation. Most of these tumors, they present with either a T3 and a T4 disease or a N2 and a N3 disease. And majority of them, simply because locally advanced in presentation, receive neoadjuvant chemotherapy. So coming to the other important subgroup of epithelial tumors, the ER negative. So the ER negative, again for the sake of simplicity, is divided into one with good prognosis, intermediate prognosis, and a bad prognosis. The adenoid cystic or the secretory, the typical salivary gland-like tumors are the ones which have an excellent prognosis in spite of being ER/PR negative. So the salivary gland and the secretory carcinoma, which approximately constitute approximately 1% of these breast carcinomas, ER/PR negative tumors, in spite of being TNBC, they seem to have an excellent prognosis. They have a basal-like molecular profile, and they have and 100% 10-year disease-free survival as well as an overall survival. Majority of these tumors are N0 at diagnosis and hardly any metastasis is known. And treatment is as per the stage. Chemo is only being considered for N-positive disease because generally N-positive disease is not commonly seen. Another excellent prognosis in this group of ER-negative tumors or a TNBC tumor is secretory carcinoma, which is also a salivary gland type tumor. What is pathognomic of this is the NTRK gene fusion, and that is why possibly the role of these oral TKIs in the metastatic disease, the entrectinib or larotrectinib. Chemotherapy definitely is indicated for the N1 disease, although these are not very chemosensitive tumors. Another important one being the IDC with medullary features. So not long back, it was considered as an independent subtype. So now we know that now it is considered as the part of the NST pattern only with no distinct subtype. The unique pattern about it is one of those still rich TNBC and belongs to the broader group of BRCA related tumors. So BRCA-ness is a characteristic of this and has a much better prognosis than other grade 3 TNBC. Chemotherapy has definitely shown to improve outcomes T1B onwards, and generally if the tumor is detected, NACT should be the focus, in spite of the fact that the PCR rates in this subgroup is less than the typical TNBC that we see. Another tumor with an intermediate prognosis, is one with apocrine differentiation. And again, another characteristic of this tumor is the androgen receptor positivity. This is a subgroup that is found to be androgen receptor positive, although we do not know how to use this knowledge in upfront treatment of these tumors. They are treated just like IDC, and majority of them, because of locally advanced presentation, are treated with neoadjuvant chemotherapy. Again, the PCR rates seem to be much lower than the other TNBC. At present, the treatment with androgen receptor antagonist is not currently recommended outside of a clinical trial. So going further, we come to the subgroup, the one with the worst prognosis, worse than any other subtype, that is the metaplastic carcinoma, which includes squamous cell carcinoma also. Fortunately, it accounts for only 0.5% of all the breast cancers. It's invariably a grade 3 tumor to present with a triple negative and also a P53 positive basal-like tumor, and the 5-year disease-free survival is to the tune of only 55%. It has worse prognosis considered among all the breast cancer, the other subtypes. Usually, in spite of being N0 at presentation, the local and the distant relapses in this subgroup are very, very frequent. This is one subgroup where even in early breast cancer presentation, even after mastectomy and a lymph node negative disease, there is some evidence to say that adjuvant radiotherapy may be helpful and may improve survival. Usually are chemo resistant. Nevertheless, anthracycline, taxanes, all are given. Even there might be some consideration for addition of platinum and other novel agents. Invariably, metastatic disease, or most of these patients will invariably land up with metastatic disease. If platinum or anthracyclines not given earlier, then maybe tried in the metastatic setting. Approximately to the tune of half of these, 46% of these are PD-L1 positive. Might be an attractive option for adding immunotherapy. We do not really know how these patients do. In spite of adding immunotherapy, the prognosis generally remain very poor. There is some data from MD Anderson, where these tumors have been treated with that and day regimen, where liposomal Adria and bevacizumab and the mTOR inhibitors have been tried. And in a subgroup with PIK3 mutation positive, the response rates were to the tune of 40%, looking at the overall bad prognosis, which is still quite encouraging. NGS is generally recommended to identify more and more targetable mutations in the need to identify some solutions to this tumor. So to summarize, the rare epithelial tumors on an overview can be broadly subdivided into a ER positive group or a triple negative group, and a group which is a HER2/neu positive. And across the entire spectrum, we have tumors with an excellent prognosis like tubular, cribriform, mucinous, to tumors with a very bad prognosis like metastatic carcinoma. Or another thing to note is that these two tumors with neuroendocrine differentiation and the tumors with medullary differentiation, although they were considered as two different subtypes earlier, in the latest classification, they are now being considered as part of NST only, with neuroendocrine or with medullary differentiation. Last but not the least, coming to the non-epithelial tumors, the phylloids one needs special consideration. Needless to say that they are divided into benign, borderline and malignant. Majority of what we see in our practice, they belong to either benign or borderline, approximately 80% of these cases. But 15 to 20% of these cases can be belong to the malignant subgroup. And malignant phylloids definitely has a very, very bad prognosis, behaves like sarcomas, localized tumors, just like any other soft tissue tumor. Surgery is the way to go. With 1 centimeter should be the adequate excision, that is the margin that should be tried at. No adjuvant systemic therapy if margins are free and we have adequate margins. However, with metastatic tumors, chemotherapy is the way to go, just like any other sarcoma. Going further, I would like to conclude by saying that it is important to recognize the rare breast cancer histological subtypes. Broadly, the pure subtypes seem to have a more favorable prognosis, and more you find the mixed subtypes are the ones with not so favorable prognosis. Central pathological review is mandatory because in 20%, again, the diagnosis might change after the central pathological review. Each subtype needs to be graded further. Each subtype needs to have a ER/PR HER2/neu, and that may help in taking into and help us in guiding the prognosis. Genomic testing is not routinely recommended for treatment decisions because all these genomic tests were actually developed for the IDC group. However, still molecular profiling as part of the clinical trials may help us to understand these tumors further. The TNBC special subtypes may have lower pathological CR rate than the typical TNBC. However, still wherever NSCT is required, we go ahead with NSCT. Neuroendocrine tumors no longer seem to be a separate entity, just like medullary tumors, which are no longer a separate entity. For knowing these subtypes, knowing the aggressive entities like the pleomorphic lobular carcinoma or the micropapillary may help us in treatment escalation, or knowing the indolent variants like tubular or cribriform may help us in deciding about treatment de-escalation. Specific targets are being recognized. Maybe in the future we will have medicines to target them also. Malignant phylloids, though rare, but needs to be recognized. And whenever we find any of these rare subtypes in the breast, another endeavor should also be to rule out possibly metastasis to the breast, which is seen in 1% of the cases, especially whenever we find the metaplastic or the lobular or the papillary variant. And with that, I say thank you. Thank you for patient listening.
Thank you, Meenu, for a wonderful presentation. And I really enjoyed that because it's not often that we get to listen to the rare subtypes, and they're really important to recognize in the clinic. Our next speaker is Dr. Priya Tiwari. She's going to talk to us about the role of anthracyclines, platinum salts, and alkylating agents in the adjuvant therapy of triple-negative breast cancer. Priya is a senior consultant medical oncologist at the Artemis Hospital in Gurugram.
Thank you, ma'am. Thanks a lot for the words, and thanks organizers for giving me this opportunity. So just let me make the presentation. Yes. So I'll be talking about early breast cancer, triple negative, and the role of chemotherapy drugs, anthracyclines, platinum agents, and the alkylating agents in the adjuvant therapy. Though we should know that there are certain, especially for the platinum salts, there is not much data in the adjuvant setting. What is important is about the TNBC cohort is that it is a very aggressive subtype, as all of us know, and it's a smaller cohort compared to the ER positive patients. And though the idea about TNBC existed for a long time, it's only that the research exclusively focusing on the TNBC patient is more of a recent origin. This group of patients are more chemosensitive compared to the other types of breast cancer. However, we do know, and by our clinical experience, that there are always patients who might not respond to any chemotherapy and where the disease behaves in a very aggressive manner. So overall, it's a heterogeneous subgroup. There is a lot of discussion about the BRCA, about the BRCA positivity, about the BRCA-ness in this group of patients. Though it is still a very small group of patients, TNBC in majority of cases might still be a non-BRCA disease. Now, when we are talking about options in the localized TNBC, in other forms of breast cancer, a lot of research has taken place beyond the chemotherapies. However, unfortunately, in TNBCs, we are still just focused on the chemotherapies. And though there is data of immunotherapies in the metastatic setting, there is data of maybe bevacizumab, and now we have PARP inhibitors. Somehow in localized TNBCs, the chemotherapies are only the way to go forward. What is important is that the backbone of chemotherapy regimen is formed by anthracyclines, more recently taxanes, and the age-old alkylating agents. And there is some discussion about the platinums also. However, the guidelines still do not uniformly recommend platinums in the management of either neoadjuvant or the adjuvant chemotherapy regimens. So yes, what is important is that these are the group of patients where the disease behaves very aggressively. So people have tried to intensify dosing regimen. Intensification can be achieved by increasing the dose of the drug. It can be achieved by dose dense regimen. That is from 3 weekly, you make the regimen 2 weekly, or you use the drug in a sequential manner so that you are able to increase the dose of the drug. And now we also have discussions of maintenance chemotherapy options, especially capecitabine, to decrease the recurrence rate and improve overall survival rates. So discussing the alkylating agents first, as they were the oldest agents to be tried in breast cancer. Besides cyclophosphamide, we are not using any other alkylating agent in the management of breast cancer or for TNBC as per se. You can see the NCCN list of the drugs in the regimen, and you can see that all the commonly used regimen, either in the adjuvant setting or the neoadjuvant setting, have cyclophosphamide as one of the main component of the treatment. There are certain regimens, especially you can see the lower down the list with paclitaxel and carboplatinum. Yet for all the practical purposes, and we already know from our clinical practice that cyclophosphamide based regimen are the important ones. Now, this was one of the trials, just to put things in perspective. Adjuvant cyclophosphamide, methotrexate, and 5-FU based chemotherapy node positive breast cancer. One of the first combination chemotherapy trial for the breast cancer. You can see on the screen the results of 20 years of follow-up, and you can definitely see that the relapse-free survival was better after the addition of chemotherapy, and overall survival was also better compared to the control arm. The results were good, similar in the patients who had premenopausal versus postmenopausal. So we do know that beyond hormonal ablation, chemotherapy did work in these patients, and it showed survival advantage. The trial used 12 cycles of chemotherapy, and subsequent trial there was another trial which showed that the 6 cycles of chemotherapy is as good as 12 cycles of chemotherapy as far as the CMF regimen is concerned. Now, besides neoadjuvant and the adjuvant setting, we have cyclophosphamide maintenance trials also in place, and you can see this was a trial where cyclophosphamide and methotrexate maintenance for hormone receptor negative early breast cancer was conducted. More than 1,000 patients were taken. You can see the dosing there. Daily 50 mg dosing schedule of cyclophosphamide was given for 1 year. Now, focusing on the triple negative cohort, the results were not different in the patient who had maintenance versus the patient who did not have any maintenance. However, if you focus on a node positive cohort, you can see that there is a suggestion that the maintenance might work better in these group of patients. However, the results were not statistically significant. but it can be hypothesis generating, and it can give us more options to try in the maintenance treatment. We already know that there is data of capecitabine now coming in. So yes, so this was after alkylating agent, the world moved towards anthracyclines. Now, anthracyclines are also one of the first line drugs for the management of not just TNBCs, but all subtypes of breast cancers. And somehow it is known that from the trials, from the mechanism of action, that they are more effective in HER2 positive patients, maybe compared to the other subtypes. Because of their long risk, because of their concerns of long-term toxicities, especially cardiotoxicities, AML, MDS, now the world has started moving from 6 cycles to 4 cycles, and now there is emphasis, growing emphasis on anthracycline-free regimen also. Now, since they have such a long-term toxicity, what we also need is that there should be kind of biomarkers which can help us to predict which are the group of the patient where the drugs will be beneficial, and which are the group of the patients where we can actually spare the toxicities of anthracyclines. But unfortunately, we still don't have either a biochemical, a clinical, or maybe a lab biomarker to predict the responses or resistance to anthracyclines. Now, this was one of the meta-analysis, anthracyclines versus CMF. What it showed that the 6 cycles of anthracycline-based regimen, initially the trials were all conducted on the 6 cycles of chemotherapy, 6 cycles of anthracyclines, but the 6 cycles of anthracyclines have more cardiotoxicity and more risk of AML, MDS. However, initially the 6 cycles of anthracycline showed that they fared better compared to that the previous standard of treatment, that is the CMF-based chemotherapy. If we try to decrease the number of cycles of anthracycline from 6 to 4, the results became actually comparable. So 4 cycles of AC-based chemotherapy was comparable to standard CMF-based regimen. Now, because as I was already speaking about improving the results, and that applied to the anthracycline-based regimen also, the concept of dose-dense regimen came up. And again, you can see on the slides here, the EBC-TCG, the patient level meta-analysis of 37,000 patients, which compared 2 weekly versus 3 weekly schedules in hormone receptor negative early breast cancer. Now here the dose-dense schedule reduced risk of breast cancer recurrence by 17%, absolute reduction 4.3% in 10-year risk of recurrence, and 2.8% reduction in 10-year risk of breast cancer death, and with no increase in non-breast cancer death. So I think that has also become a clinical practice to use dose-dense regimen, and especially in young and patients where the tolerance is not a major issue. Now, as I was already discussing about the long-term side effects, and there's a certain amount of data that the anthracycline-based regimen are more useful in HER2 group of patients, and their clinical usefulness and effectiveness might be put in question in the patients who have hormone-positive disease, or patients sometimes in TNBC also. So this was one of the anthracycline-sparing regimen, and there you can see docetaxel with cyclophosphamide was compared with doxorubicin and cyclophosphamide. They used 4 cycles of chemotherapy in patients with operable breast cancer. It was a beautiful study conducted by US Oncology Research. On the right-hand side, you can see the graphs. The disease-free survival and the overall survival actually favored the Taxol-based regimen compared to the anthracycline-based regimen. So taking this further, the exploratory analysis from the forest plot of DFS, you can see highlighted in the box in the triple negative cohort also, the Taxol regimen was better compared to the anthracycline-based regimen. So even the NCCN also mentioned this as one of the major regimen which we can use for our patients. So just to summarize the results as of now, 6 cycles of anthracycline containing combinations better than 6 cycles of classical CMF, 4 cycles of anthracyclines, combination not superior to 6 cycles of classical CMF, dose dense superior to standard schedules in hormone receptor negative tumors, and 4 cycles of TC better than 4 cycles of anthracycline containing regimen. So yes, all this discussion because we want to decrease on the sides of anthracyclines. Anthracyclines are the group of drug which should be used very judiciously. 4 cycles AC versus 6 cycles AC, lower risk of cardiotoxicity, as you can see from the screen, with the 4 cycle regimen. And that is why now we are using more and more. I don't think so anybody is now using 6 cycles of anthracycline based chemotherapy. Most of us might be using 4 cycles of chemotherapy. The taxane here has helped us a lot. They have helped us to reduce not just the dose, but especially the dose, and also have made us to use more of a dose dense regimen. So 4 cycles of AC, you can see the risk of cardiotoxicity is around 1% with 0.3% risk of acute leukemia or MDS. With 6 cycles of anthracycline regimen, we have 2% risk of severe cardiac toxicities, grade 3, grade 4 that we call, and 0.5% risk of acute leukemia. So any chemotherapy regimen that we are using in the neoadjuvant and more so in adjuvant setting, we should have a benefit which should be able to compensate for these kind of long-term toxicities. So yes, this was again a very interesting trial, and actually we have certain other contradictory trials as well. West German study plan B trial. Now what this trial did was the adjuvant 4 cycles of epirubicin and cyclophosphamide plus docetaxel versus 6 cycles of docetaxel and cyclophosphamide based regimen. As you can see by the randomization, 6 cycles of docetaxel plus cyclophosphamide, and then there was another group where they used all 3 drugs in the sequential manner in the HR negative group. Now you can see from the graph and you can see from the list of the various subgroups also that there was not much difference, you know. So you again have an anthracycline sparing regimens which are now finding clinical trial results also, and maybe clinical usefulness also. And it's very important where there is a risk of toxicities, especially in the early cases, early stage cancers. You can use these regimens as an anthracycline sparing options as well. Now coming to the platinum agents, a lot of discussion about platinum agents, especially because they have been shown to be effective in the BRCA subset of the patient. Importantly, the data is there in the neoadjuvant setting because we can measure the responses in form of patch CRs. However, there is paucity of data in the adjuvant setting. There is no head-to-head comparison between cisplatinum and the carboplatinum. And yes, the different cohort of triple negative patients, the BRCA cohort, the BRCA-NES cohort, and the non-BRCA cohort might show different responses to the platinum group of drugs. So yes, this was just a poll we conducted just to know what is the common practice. Has platinum started seeping in our current practice as well? There were 59 responses among our medical oncology colleagues. Now there are 2 kinds of responses, one in the NACT you can see and the other in the adjuvant setting. So people are still not using it in the adjuvant setting here, but you can see that in the BRCA positive patients, yes, the patient there is increasing use, and yes, 11.9% in the adjuvant setting for any TNBC will use it. Since the data has now come up in the neoadjuvant setting, you see more increasing use of the platinums in the neoadjuvant setting. And you see still 50% people are not using it, but yes, there is more usage in the TNBC cohort, and also yes, in the BRCA positive patients also the people are doing, but I'm not sure if everybody is getting BRCA done in all the TNBC patients, or we are just following certain age cutoff for doing TNBCs. So yes, the rationale for platinum and the alkylating agents in triple negative breast cancers, because we know that a subset of these patients might have certain kind of genetic abnormalities, BRCA being one of them. The other could be BRCA methylation, low expression of BRCA messenger RNAs, and other kind of BRCA-NES. Now what happens is any cell which is deficient in either homologous recombination repair or the non-homologous end joining error prone will be susceptible to the drugs which work by causing DNA damages, and that is the platinum is one of them, alkylating agents is one of them, and there are certain other chemotherapies also. But what is important is to know that yes, there are subset of TNBC patients, we might not show any kind of these abnormalities. So yes, there are a lot of trials. Now, important thing is here to know is that the adjuvant trials are not here as far as the platinums are concerned, but we do have a lot of new adjuvant trials. Now, the problem with the new adjuvant trials is that they have focused largely on patch CR. Patch CR, though, has shown that it might be a surrogate marker for long-term outcomes such as DFS and OS. Somehow in certain clinical trial, it has not materialized, and we have found conflicting results. You can see here to quote the 2 trial, the GPAR-6 trial and the CAL-GB trial. For the TNBC patient, you can see the 2 arms of the GPAR-6 trial. It had a carboplatinum arm and it had a non-carboplatinum arm. It did not have an alkylating arm. And other is the CAL-GB trial. Now, what is important is to know here is after the addition of carboplatinums, you definitely see an improvement in the patch CR rates. As you can see in the GPAR-6 also up to the tune of 16%, and in the CAL-GB also up to the tune of 13%, which was both clinically significant as far as the patch CR rates were concerned. However, when we came to actual clinical parameters, you see in GPAR-6 it it did reflect into the DFS survival. 3-year DFS rate was 85% compared to 3-year DFS rate of 76% in the non-carboplatinum arm, and that was also statistically significant. However, in CalGB trial, we just see a trend towards improvement, but the results were not statistically significant. Now, if you take just PAS-CR as a surrogate marker, the chances are that you might again find a clinical discrepancy, so we need to find better surrogate markers. There are other pointers to explain these differences. The one reason could be that there is no that the alkylating agents were missing from the JPAR-6-2. They were, however, the dose as AC regimen was there in the Alliance trial. We do know that the alkylating agents also work in the TNBC cohort via the mechanisms as already explained by the platinum group of drugs. So that might be one of the reasons. Then sample size is one reason where we could see that the results might not be a proper estimation of what is actually happening. Also, what is important is to know in the JPAR-6-2 trial, there was a lot of attrition rates in both the arms, and a lot of chemotherapy drugs patients were not able to take because of the tolerance issues. Now, this is a very important trial, preoperative cisplatinum versus AC. Now, this was a germline BRCA1 and 2 mutation, because a lot of people think that as soon as there is a BRCA mutation, we have to use cisplatinum. These patients are highly sensitive to cisplatinum, and maybe even a single drug suffice. So this was a trial which randomized patients of the germline BRCA mutation. You can see the randomization. They used cisplatinum single agent 3 weekly for 4 cycles, and AC regimen was compared to, that is a doxorubicin cyclophosphamide regimen. Now, as by the graphs on the right side, you see that the PAS-CR rate comparing cisplatinum versus anthracyclines, and you see that the PAS-CR rates were better in the anthracycline combination arm compared to cisplatinum. We might say that maybe cisplatinum combination would have fared better, but at least cisplatinum single agent did not fare good compared to the combination. Again, as I already said, that even these chemotherapy drugs have some role to play in the TNBC's pathways of drug sensitivity. So also from other trials, it has been seen that the platinum alone is not that good even in the HRD tumor. And why is that so? Because platinum acts via 85% intra-strand crosslinks, which are repaired by NER, that is the non-homologous pathways. Now, only 15% of cisplatinum DNA damage are inter-strand crosslink where HR repair is needed. So whenever if you talk about BRCA pathways, BRCA-NES pathway also, you have to take into account these figures also. And cisplatinum single agent might not be the best option even in these group of patients, though they might have a better sensitivity and maybe a more PAS-CR rates in this group of the patient. So as of now, most of the regimens worldwide do not recommend using platinum in the frontline management, either in the localized or in the neoadjuvant or the adjuvant setting. But what is happening is in the triple negative cohort, that since response evaluation has become one of the very important markers, so most of the adjuvant regimens are shifting to neoadjuvant. The threshold of using neoadjuvant chemotherapies is going down in the triple negative breast cancer. But as far as the platinums are concerned, their inclusion in the neoadjuvant setting remains controversial. In the adjuvant setting, is that there's increased PAS-CR rate. However, long-term outcomes are still, the results are not very clear. And you can use them only if you feel that you need to have rapid improvement in responses. The tumor size is actually big, where you want to give patient benefit of more chemotherapy drugs. So just to conclude, cyclophosphamide has been and remains standard of care in the either neoadjuvant or adjuvant setting in the TNBCs. The value of anthracycline and adjuvant therapy of TNBC is a matter of what you can see here, that yes, some kind of debate needs to be discussed. We have always used anthracyclines in TNBC patient, but now there are options, there are trials which are questioning the benefit. And yes, we need the proper, much better trial with larger patient population to find out which are the groups of the patient, whether this is a high lymph node burden, where anthracyclines can actually be still be a standard of treatment. Yes, and of course, the 4 cycles of anthracyclines, irrespective of whether it is dose dense or not, seems to be less cardiotoxic than 6 cycles, which is such a respite. And after the use of this taxane-based regimen, it is possible to decrease the number of anthracyclines chemotherapy to 4 cycles. So yes, and the moderate increase in the DFS expected with anthracycline should be balanced with the long-term risk of cardiotoxicity and the leukemia MDS, and this should be always discussed with your patient. Importantly, use of platinum salt in NSCT setting for TNBC is an option for select patient, but there remains some controversy based on inconsistencies with respect to long-term outcome trials. And yes, the important role of patch-CR is in this setting. But yes, of course, we need better markers and better trials with long-term outcome. Neither BRCA mutation status nor HRD is sufficient to select patient for the neoadjuvant platinum. Selection currently has to rely on individual risk, need to achieve a major response, and the other factors. Yes, so the treatment of TNBC, as I already said, should be carried in NACT setting, which allows us to react to the response, and so that if there is another possibility of using maximum benefit of chemotherapy or the maintenance treatment can be given to the patient. So yes, and due to the lack of the data, platinum is not recommended in the adjuvant setting. But I can see that from the table, from the poll that I put in, many people, many oncologists will beg to differ from me on this statement. Thank you.
Thank you, Priya, for a very comprehensive review. I'm sure there are going to be a lot of questions after this. So without further ado, I will start with my talk. And the topic for today is precision oncology in metastatic triple negative breast cancer. I don't know how to make it full. Here. Yeah. Can everybody sees that clear?
Yes.
Yeah, okay. So basically, as we all know, that triple negative breast cancer is not one, but many, many diseases. And we have had many classifications of TNBC. The most practical one is Bernstein's, where he's come up with 4 different categories. And what we see is you have basal-like divided into the immunoactivated and immunosuppressed. These are characterized by complex genomic profiles, a large percentage of P53 mutations. In the immunoactivated, you will get a higher frequency of homologous recombination deficiency. These patients will achieve PCR at a very high rate, and a lot of them are triple negatives. Immunosuppressed have lower TILs and they have lower PCR rates. Then we have the mesenchymal and the luminal androgen receptor, both which have lower genomic complexity. The mesenchymal has an activation of the PIK3 pathway and intermediate levels of PAT-CR, whereas the luminal androgen receptor has been characterized by a luminal subtype. It mimics the luminal cancers by mutations in PIK3, AKT, GATA, and CDH1. It has a low amount of TILs and low levels of PCR. And there are multiple therapeutic options. So these diseases, as I mentioned, have distinct histology, genomics, and immunological profiles. Chemotherapy is not the only option here, and we have made some progress, albeit not too much, in the therapeutic armamentarium, and we can offer our patients platinum-based chemo. You just heard Priya talk on it, PARP inhibitors, immunotherapy, ADCs like sacituzumab, and TRAC inhibitors. Unfortunately, none of the targeted therapies to date have demonstrated any overall survival benefit. Let's talk a little bit about the genomics and the immunoprofiling of metastatic TNBC. So there are a lot of somatic, so this was a very elegant study carried out where somatic alterations were looked at 617 metastatic breast cancers, and 182 of them were triple negatives. And you can see that there was an increase in loss of functional mutations in the HRDNA repair genes and also in the PIK3CA AKT pathway. So these are the different mutations that you see in the triple negative, and you can see that they are mainly in the PIK3 pathway. And this was again confirmed in another study by Rizavi et al., where again there were mutations in the PIK3CA, P10, and P53. Now, another very elegant study was performed and genomic profiling was done from the paired samples of 43 triple negative breast cancer patients. And here they found, if you look at the tumor mutational burden, which is an indicator if it is grossly raised more than 10 or more than 20 mutations per megabase, then immunotherapy seems to work pretty well. But you can see that in these patients that the shifts in the tumor mutation burden between the primary and metastatic tumor were almost minimal. And this was also born in its molecular subtype and TILs. So this is data from the same study, which shows that the difference between the primary and metastatic occurs in such a way that the immune activated becomes more immunosuppressed. And there is a shift. And actually, if you look at the TILs between the primary and metastatic, the TILs actually reduce as the patient goes through multiple metastases. So what happens in a more and more metastatic tumor is that you get a very immunosuppressed background at both the pathological and transcriptomic levels. And the question that begs to be asked is, does this account for the relative resistance to immune checkpoint inhibition, especially in the later settings of metastatic disease? Because we've shown very disappointing response rates in these patients. There is a proposed algorithm for the current treatment of metastatic triple negative breast cancer. And the first thing you would want to do is to confirm the diagnosis by indeed confirming it is ER, PR, and HER2 negative. Your next step would be probably looking at PD-L1 positivity, which you know is present in 40% of these patients. And the patients can then be offered atezolizumab with nab-paclitaxel, which today has level 1 evidence. A more recent trial of pembro and taxane was presented at ASCO this year, and I'll briefly describe it a little later. If your patient is PD-L1 negative, your options are chemotherapy. If there is a germline mutation, you can offer platinum or PARP inhibitor. If the MSI is unstable or MSI high, you can offer pembro. And of course, NTRK fusions, which are extremely rare, less than 1%, qualify the patient to get entrectinib and larotrectinib. Once they fail all these treatments in your more heavily treated 3rd and 4th line setting, the ADC saxituzumab, unfortunately, which is not available here, can be certainly tried. Molecular profiling can be done if patients are being enrolled on clinical trials. And these are all the mutations and the androgen receptor genes and signatures that you look for. And these are the possible drugs that you could offer these patients. The problem is that no single assay or platform can give you all the information you need. So not only do you need IHC, which is on a tissue-based analysis, where you look at ER, PR, HER2, you look at PD-L1, you quantify the TILs, you look at the mismatch repair proteins, you do a pan-NTRK antibody screening and an AR assessment. You definitely need genomic tests. You need to look at germline, BRCA, and nowadays we are doing panels to look at other significant genes like PALP2 to confirm MSI, to look at tumor mutational burden and mutational signatures. Transcriptomics also comes in for other immune response signatures. And what could be a possible strategy so that you can follow a treatment algorithm which is more or less streamlined is that you can do a combination of IHC and you can do a combination of somatic and germline genetics. If ambitious, you could also go for a mutational profiling which can identify other actionable targets. The problem is that this is currently available only in academic and commercial centers. These therapies all seem to be FDA approved, and mutational profiling, as I mentioned, can allow you to enroll patients into trials. The technology may not be readily available in every part of the country, and some trials will still require further additional pathology workup. Is there a sequence that we can follow in our clinic? So at first metastatic diagnosis, do what is targetable, do what is available. So ER, PR, HER2, PD-L1, TILs, simple to do, BRCA1, BRCA2, MSI, and perhaps NTRK. There is a controversy upon progression, whether you would like to re-biopsy these patients and sequence them, or easier than that, do a cell-free DNA analysis. There are several approaches available: targeted sequencing, droplet digital PCR. Then it is important to remember that the circulating DNA detection is high because of high tumor burdens in metastatic TNBC, and it can range from 63 to more than 95% depending on the method that you use. This kind of negates the problem or overcomes the problem of heterogeneity that we're all worried about. And you can do further genomic profiling on the cell-free DNA. So the first treatment that has been FDA approved for PD-L1 positive, locally advanced or metastatic triple negative breast cancer is the antibody atezolizumab, which is a PD-1 inhibitor, and also the FDA has approved simultaneously the Ventana PD-L1 SP142 assay, which has now been validated in India, and both the companion diagnostic and the drug are available. The problem is if you look at NCCN guidelines, it doesn't mention the setting. It just says that it can be used, but the data is for the first line setting in this disease. So I think that is where you get the biggest bang for your buck. So these are the results for Impassion 130, where you can see the overall survival analysis. At 2 years, you can see 54% of patients were alive with the combination versus 37% alone with nab-paclitaxel, and there is a 9.5-month gain in overall survival. But it's important to remember that advanced triple negative disease is not an immunogenic tumor. You need enrichment. So in the first line untreated metastatic setting, you have 2 trials. You have the Impassion and the Keynote, and in later lines, you have pre-treated metastatic trials, the Keynote 119 and 086, which have thrown up very disappointing response rates ranging from 8 to about 23%. PD-L1 expression matters, as I've shown you, and the SP142 on immune cells with atezolizumab, and the CPS score generally more than 10 in the 355 study with Pembro. There is a heterogeneity of PD-L1 levels, and I don't think I will ever understand this, but there are millions of scoring systems. And if we try to bring them together and compare them, you have the tumor proportion score, which is 10%, and there are different methods of defining each of these scores. And this is mainly for the PD-1 inhibitors. Then you have the immune cell proportion score. Then you have the CPS, or the combined proportion score. And finally, the ICA, which is the immune cell area score, which is what we do for atezolizumab. So a 10% TPS is equivalent to a 10% IC, is equivalent to 21% CPS, and that is equivalent to a 1% ICA. So this is the rough comparison of all these different scoring systems. We don't use a lot of them. CPS is used largely in lung, but now we are using for Pembro in TNBC as well. What about PD-L1 positivity in untreated metastatic triple negative? So as you can see here, 40% of the patients in this study had PD-L1 positivity, and you can see that the status in the primary is much more than in the metastasis. And even among the metastasis, it is mainly in the breast and the lymph nodes, and the PD-L1 positivity is certainly lower in the liver and the lung. So even within the metastasis, it differs by anatomical location. This is more data from the Impassion study, and they divided their patients into PD-L1 low, positive and high positive. The low was between 1 and 5%, the high was more than 5%, and you can see that there was no difference in the magnitude of atezol effect whether you had high or low, and both groups seem to benefit. If you look at the TILs, and many of the PD-L1 positive patients were also TIL expressed TILs, and here you can see 21% had an overlap. And you can very nicely see over here that if you have patients with a high TIL, more than 10%, they seem to do much better with immunotherapy, and this is borne out in this forest plot as well. What about the BRCA1 genotype? And this is a question very often asked, that if you have a BRCA1 positive patient who's also PD-L1 positive, what would you offer go first. So you can see about a small percentage of about 99 patients were BRCA1 mutant in the impassioned study, and they were equally divided between PDL1 positive and negative. So BRCA does not enrich for PDL1 positivity, and you can see here that irrespective of whether mutant or wild type, the benefit magnitude was the same with atezolizumab. What about the monotherapy design? So these are for patients who've received more than one treatment. They are not treatment naive. They've received one or two prior treatments, and they received monotherapy with Pembro versus investigator choice. And if you look at the results, you can see that it was not very impressive in the intention to treat or in the CPS more than or equal to 1 or more than or equal to 10. And the difference started really emerging in the results when you looked at the CPS more or less more than or equal to 20, where you could see a difference with a hazard ratio of 0.58. And there is a relationship in this study seen between the TILs and the outcomes of pembrolizumab versus chemotherapy. You can see that in the responders, the TILs levels were much higher. And in this curve, you can see that the OS by TILs, so these are the patients which had low TILs, and here the patients did much better with chemotherapy. The blue line is Pembro and the red line is chemo, whereas in the patients with a higher amount of TILs, you can see that they did better with the immunotherapy pembrolizumab. And if you look, this is data from the most recent study presented at ASCO, the first line study, which is similar to the impassioned design, 355, only the drug is different. It's pembrolizumab in combination with taxane or gemcarbo. And you can see that at the cutoff of CPS more than or equal to 10, you certainly had a benefit in progression-free survival or death with a hazard ratio of 0.65. The delta was about 4 months. Switching gears, what are the patients? So we talked and Priya alluded to the fact that it's not only BRCA mutation we should be looking at, but we should be looking at other HRD defects and other mutations as well. So hereditary mutations make up, like BRCA 1, 2, PALB2 make up about 5%. And then somatic mutations make up another 3%. And then if you look at the epigenetic changes, which is the methylation of the BRCA and the RAD51C mutation, that makes up another 5%. And we have unknown mutations in approximately 5%. So you have 18% of patients that do have a defective HRD. And these are the various biomarkers that have emerged. The first two are quite clear, that is germline BRCA and somatic BRCA. And then you have RNA and protein expression signatures which are diagnosed with or which are detected with microarrays. You have the HRD score, HR detect and mutational signatures which are detected through whole exome sequencing which require tumor DNA. These are functional biomarkers. And finally, very interesting, RAD51, which is a very important protein for homologous recombination repair, is a dynamic functional biomarker, and I will show you a slide on this when I end. So these are the three studies. The Bravo trial, which was prematurely stopped because I think there was a problem with the control group, and then the Imbraca and olaparib, and you're all aware that they showed a PFS benefit between 4 and 5 months. There was no OS benefit seen in these studies. These patients had received 2 or more previous lines of treatment. They all had germline BRCA1 or BRCA2 mutations, and they were 1 year out from their previous treatment. The primary endpoint was PFS. What about going beyond BRCA? So this is a very nice study called Beyond BRCA using talazoparib, and they used a number of solid tumors, of which breast made up about 13 patients, and they were mainly hormone receptor positive. And if you look at the waterfall plot here, you can see partial responses in 4 of the breast patients, and 3 of which had PALB2 mutations, and the other 2, which had stable disease, also had PALB2 mutations. So these are the type of tumors which will also show response to PARP inhibitors. What about other germline HR pathway mutations. So there was a very nice study presented at ASCO this year called Olaparib Expand. And this included a cohort of 54 patients with ECOG 0 or 1. And a panel of mutations was done in these patients. And what was found is, and these were all non-BRCA germline and somatic BRCA. And what they found is that the response was seen almost 50% in the somatic BRCA1-2 mutations. Again, a response rate of 82%, which is pretty impressive in the germline PALB2 mutations. These are early days yet. This was a proof of concept study, but no responses were observed with ATM-CHEK2, and this will be taken further, where there will be a randomized trial which will address this issue. Now, there is data from the JEPAR 6-dose study, and 193 triple negatives were included. This was also referred to, I think, by Priya, where carboplatin, in addition to non-pegylated liposomal docs with paclitaxel, gave you better and higher PCR rates. So what they looked at as a biomarker was the HRD score. HRD score is just calculates the genomic instability status, and they use these 3 parameters. It is a continuous score from 0 to 100, and anything more than 42 is considered to be a positive HRD score. And what they found in patients with these or a high HRD scores, they found that 81 of these 136 HR deficient patients had a high HRD score but no BRCA mutations. And those patients also had a good PCR, and adding carboplatin to the chemotherapy increased the PCR rate, similar to what it does in the BRCA mutated patients, from 33 to 63%. The last slide I will show is on the RAD51 foci formation. So RAD51, what is it? It is just a recombinase DNA recombinase. It is a protein. It is a key component in the pathway of homologous recombination repair. And in response to double-stranded DNA breaks, the RAD51 forms foci at the sites of damage that can be visualized by fluorescent microscopy. And what you want is more than or equal to 5 nuclear foci. And a low RAD score in sporadic cancers is indicative of deficient homologous recombination and correlates with PCR. So you can see very nicely in the post-chemotherapy, those with a low RAD51 score had a good BAT-CR and also were mainly triple negative. So it is one way of indirectly telling whether HRD is present in the patient or not, and there is a defect in the HR pathway by calculating the RAD51 score. So basically what I've tried to cover today, more than just clinical trials, is what are the different emerging concepts, the concepts in metastatic TNBC, how we are looking at the immunoprofiling, how we are going beyond BRCA, and we are looking at HRD, and we're looking at RAD51, and trying to look for more targets for both immunotherapy and for PARP inhibitors. Thank you.
Thank you, Dr. Shona. Would like to invite our next speaker, Dr. Joydeep Ghosh. He is the consultant medical oncologist from Kolkata. Over to you, Dr. Joydeep.
Thank you, madam, for the nice presentation. So moving forward, I will be discussing the important breast cancer abstracts that was presented in ESMO last year. So I have selected 4 abstracts. 2 of them are from molecular path. First one was regarding the role of TILs in predicting response, and the role of TMB and gene expression profiling in predicting response. And the third and the fourth abstracts will be on the addition of veliparib with paclicarbo, and the fourth one on ipatasertib with paclitaxel in the metastatic triple negative breast cancer setting. So coming to my first abstract, this was the study that was done to look at the immunomodulatory signature, which enhances prediction of pathological complete response to neoadjuvant therapy in TNBC with moderate stromal tumor infiltrating lymphocytes. So a high stromal TIL is independently associated with improved PAT-CR rates in TNBC. In TNBC, the immunomodulatory signature is enriched in immune cell markers and signaling, which likely represents the gene expression from both the tumor cell and the infiltrating lymphocytes. And the additional value of adding the immunomodulatory subtype to stromal DIL evaluation for predicting PAT-CR in TNBC is not known. This was the background. So the patients who were enrolled in the Artemis trial, their pre-treatment biopsies and PAT-CR assessment was done. So these are the methods. The pre-treatment core biopsies underwent standard paraffin embedding and was evaluated for TILs, including HE staining. Separate core biopsy sample was immediately placed in formalin and RNA, and RNA extraction was done, and they underwent transcriptomic profiling using the Affymetrix platform. And the standard Vanderbilt subtypes were used for classifying the TNBC. And the TILs were classified into low, moderate, or high based on less than 10%, 10 to 30%, or more than 30% presence of TILs. Now, if you look at the results, the immunomodulatory subtype was identified in fewer TNBCs with low or moderate S-tills than those with high S-tills. And although not statistically significant, the TNBC with high S-till had a numerically higher rates of PAT-CR than TNBC identified as the immunomodulatory subtype by the GEP, gene expression profiling. And they observed that the largest difference in PAT-CR rates between the immunomodulatory and the non-immunomodulatory subtype of patients was there in patients who had a moderate S-till. So the conclusions from this study was the PAT-CR rate for the TIL high group was numerically higher, but not statistically significantly different from the immunomodulatory group. And the addition of immunomodulatory signature to the TIL high or TIL low TNBC, it did not impact the prediction of PAT-CR. In patients with moderate TILs, which was the main intent of the study, the immunomodulatory subtype was associated with a higher rate of PAT-CR as compared to other subtypes. So in patients who are having moderate infiltration of lymphocytes, in them, the immunomodulatory group did better compared to the non-immunomodulatory. Now coming to the next abstract, this was regarding the tumor mutation burden and the immune infiltration as the predictors of response to NSCT. So the background is that whether TMB has a predictive role for response to NSCT in early TNBC is not known. Madam has shown that TMB is definitely one of the important factors when it comes to outcome and response to immunotherapy. But in the early breast cancer, it was not clearly defined. And to assess, this was the main objective was of this study was to assess the predictive value of TMB for PAT-CR to neoadjuvant immunodrugs and chemotherapy in TNBC from the JEPA NUOVO trial. And also to assess the predictive value of combination of TNB and an immune GEP for PAT-CR. So this was the trial design. So after an initial histopath evaluation and sampling, the patients were randomized into an initial run-in phase of Durva versus placebo. A core biopsy was done. Then the patients received either the standard taxane plus nab-paclitaxel plus placebo, and in the experimental arm, they received nab-pacli plus Durva. If they had a clinical response, they were continuing to the anthracycline plus Durva versus anthracycline plus placebo. And then the surgery was done. So basically, we had an arm where patients were given durvalumab plus the standard neoadjuvant, and in the other hand, it was placebo with the standard neoadjuvant. And sampling was done at each of these time points, and they were correlated with the response rate. So this is the consort diagram, which is visible. Nothing much to discuss. So here, they looked at the statistical significance of the presence of TMB with baseline clinical parameters. As you can see here, age less than or more than 40 years was statistically significant regarding the presence of median TMB. And also the PAT-CR, a higher TMB was found in patients who had a PAT-CR, which was statistically significant. So age and PAT-CR, these two made the lot of difference regarding the TMB. And coming to the association of PATCR with TMB, the median TMB was significantly higher in PATCR. It was 1.87 versus 1.39. And there was significant association in the placebo arm, but not in the durvalumab. As you can see here in the placebo arm, there was a significant difference between patients who had residual disease versus PATCR, but not in the durvalumab. And this is the logistic regression analysis, which shows the predictive value of TMB for PATCR in this study. As you can see here, both in the univariate and the multivariate analysis of continuous as well as dichotomized TMB, there is statistically significant improvement in the PATCR. So this study actually tells us that the presence of TMB definitely correlates with an increased PATCR. Now, if you look at the scatter plot, the patients who had a higher immune GEP as well as the higher tumor burden, they had a greater number of red spots, which are basically PATCR, compared to those who had a lower quartile of immune GEP and TMB, which had more residual disease. This is more exemplified in the scatter matrix. As you can see that 82% of the patients who had a higher immune GEP and a higher TMB achieved a PATCR. So that is significantly high. So the conclusions from this study would be the tumor mutation burden predicted the PATCR after neoadjuvant treatment in this particular trial. This result was obtained for both the arms of the study, for both the durvalumab as well as the chemotherapy alone, although the statistical significance was in the placebo arm. Both tumor, TMB and gene expression profiling, both of them individually as well as conglomerately contributed to the PATCR achievement. And this shows that a combination of TMB and GEP can increase the precision of response prediction and recommend both validation and further analysis of TMB in combination with immune parameters. So if I can summarize from last two abstracts that I presented, the first one says that the presence of immunomodulatory subtype with a moderate TIL predicts the patients who are going to have maximum response. And in the second abstract, both TMB and gene expression profile, both of them predict the PATCR. So moving forward, I'll discuss two clinical studies which were presented. The first one was the Brocade 3 trial, which is basically veliparib plus paclitaxel carboplatin in patients who were HER2 negative metastatic germline BRCA breast cancer. So this is the study schema. All the patients who were advanced HER2 negative, hormone positive patients were included. This was not a pure triple negative study. This was hormone positive HER2 negative or hormone negative HER2 negative. Less than 2 prior lines of therapy was allowed. And regarding platinum usage, less than 1 prior line of platinum was allowed, with no progression to the last platinum agent in the last 1 year. It was a 2:1 randomization. Standard arm received paclitaxel carboplatin. Experimental arm veliparib was added to this regimen. And the treatment was continued till progression, with the primary endpoint being the investigator-assessed PFS. These are the standard doses of chemotherapy, and veliparib or placebo was given at 120 milligram twice daily, and the dose was increased to 300 milligram BD and then 400 BID if tolerated after the chemo phase was over. So during the chemotherapy, it was 120 milligram BID. So as you can see here, the Kaplan-Meier shows clearly that there is improvement in the progression-free survival with a hazard ratio of 0.7. And numerically, there was a 2-month increment in the veliparib arm compared to the placebo arm. Now, patients who were TNBC as well as hormone receptor positive were eligible in this study. As you can see here in the veliparib arm, there were 50% patients who were hormone positive, and in placebo, around similar, 53% of the patients who were hormone positive. These were the baseline characteristics, which were similar in both the arms. And if you look at the baseline BRCA status, something that is interesting is in patients who were hormone receptor positive, it was 74% of the patients had BRCA2 mutation, but in the triple negative subgroup, it was 78% who had BRCA1 mutation. So this tells us that probably the hormone receptor positive patients have higher chances of have a higher chance of underlying BRCA2 mutation. So this is the efficacy based on the hormone receptor subgroup. Here also there was improvement in the PFS. The hazard ratio was 0.69, both in the investigator as well as the blinded review. It was statistically significant. And in the triple negative subgroup, here the hazard ratio is even better. It was, as per in the investigator assessed, it was 0.05, and in the independent review it was 0.07. But it was not statistically significant because it reached the upper margin of the hazard ratio of 1. As you can see here, regarding the overall survival, I do not have the data whether the adequate number of in the secondary endpoints. The response rate was around 70% in the veliparib compared to 71%. There was not much of a difference. That was also did not translate into statistically significant difference. This is the exposure summary of these of the chemotherapy agents. So on an average, 10 to 11 cycles of carboplatin was given to the patients, and regarding paclitaxel, around 11 to 12 cycles of paclitaxel was given. And this is the adverse event summary. So basically, most important adverse events were the neutropenia, anemia, and thrombocytopenia. So the conclusion from this study is that it shows that in patients who are germline BRCA mutated, veliparib plus paclitaxel carboplatin improved the progression-free survival. In both the subgroups, the benefit of veliparib was durable with an increased probability of remaining progression-free at 2 to 3 years. And the overall toxicity profile was not very different. It was manageable. Coming to the last study, that was the final results of the LOTUS-2 trial, which was a phase 2 randomized trial, looking at the first line combination of ipatasertib plus paclitaxel for metastatic triple negative breast cancers. As we all know, and it's been discussed in the previous talks, that AKT, PTEN, PI3 kinase, these pathways are important and they get activated in 7 to 8% of the patients. So with that background, this study was done in the initial phase 2 publication. In the initial publication of the phase 2 trial, it was shown that addition of ipatasertib improved the progression-free survival with a statistically significant hazard ratio. And this was the trial schema. It was a randomized 1:1 trial where standard paclitaxel was given plus ipatasertib 400 milligram once daily for 21 days, along with paclitaxel plus placebo. The co-primary endpoints were progression-free survival in the intention to treat population and PTEN low population. And the secondary endpoints were the overall survival, response rate, etc. The baseline characteristics were similar in both the arms. And this is the final analysis. So this is the overview of the OS analysis. Around 46% of the deaths happened in the placebo arm compared to 41% in the ipatasertib arm. And if you look at the Kaplan-Mears, the median OS improved from 17 months in the placebo arm to 25 months, or rather 28 months, 26 months with the addition of ipatasertib. And it had a hazard ratio of 0.8. But the hazard ratio has crossed the upper margin of 1. Now, if you look at the subset analysis, this is the PTEN normal subset versus the PTEN low subset. In both these situations, the hazard ratio was not significant, but numerically it was better in the ipatasertib arm. And also, if they looked at the PI3 AKT PTEN status by NGS, which again showed that in patients who did not have the alteration versus those who had alteration, there was improvement with the addition of ipatasertib, but it did not reach statistical significance. And this was the baseline characteristics, which shows the OS in the forest plot. As you can see here, age was the most important factor, which favored the experimental arm of ipatasertib plus paclitaxel. Regarding the subsequent anti-cancer therapies, a higher number of patients received subsequent lines of therapy in the placebo arm compared to those with the ipatasertib arm. And this is the updated safety analysis, which was more or less similar in both the arms. So the most common side effects with ipatasertib were diarrhea, alopecia, nausea, fatigue, etc. So the conclusions from this study was OS was numerically longer with the addition of ipatasertib. It improved from 17 months to 26 months, although the hazard ratio was not significant. And in all the biomarker defined subgroup, the median OS favored the experimental arm. However, because of the small numbers and the small number of events, there was probably no statistical significance. And the median OS of more than 2 years represents a meaningful outcome in metastatic triple negative breast cancers, where we all know that the patients have a median OS of around 1.5 to 1 year. So with that, I would like to conclude. If there are any questions, we would like to take up in the panel discussion. Thank you.
I think we can go over to Sudeep. Sudeep, would you like to take over now?
So thank you very much, Dr. Nag, for the invitation. And on behalf of all the audience, I would like to congratulate all the learned speakers for excellent presentations and updating us about many important aspects of breast cancer. And because your talks were so stimulating, we have had a number of questions. So what I will do is, I have the pleasure and the privilege of moderating the panel discussion, and I will straight go to the questions that have been there from the audience. So let's go to the first question, which is from Dr. Avinash Pandey. And his question is that for patients with metaplastic squamous cell breast cancer, would you change treatment to give platinum and taxane rather than anthracycline and alkylators in the adjuvant setting? And maybe Dr. Meenu Walia, you can take that first, and then any of the other panelists can also opine.
So knowing the aggressive nature of metaplastic breast cancer, I would rather be tempted to use platinum also if it has got squamous elements, but I would not like to replace anthracyclines. So although we will never have data enough for these numbers, so I would be tempted to use a AC followed by a taxane plus platinum regimen. Rather than omitting anthracyclines altogether, would like to add on platinum also if there is a squamous element.
Okay, excellent. Dr. Walia, you say that you will use AC followed by taxane and platinum given the aggressiveness of this variety of breast cancer. Joydeep, what is your opinion?
So we have around 8 patients in our hospital. All of them have been treated with the standard AC followed by taxane. We have not used platinum in squamous metaplastic.
No, but given what we know about the behavior of this disease, are you tempted to use it, or do you think we should just stick to anthracyclines and taxanes?
I really do not know whether we can apply the principles of platinum in inflammatory mammary carcinoma to a squamous cell carcinoma.
Okay, so we are not certain. Dr. Joydeep Ghosh says, and he's right, that of course we are not certain, but I wonder whether we will ever be certain given the rarity of this type of cancer and the likely fact that we are unlikely to have good level 1 evidence. Okay, we'll take the next question. Dr. Deepak Bharti has asked, why has TC still not overcome the use of AC? Why is TC not the default standard in triple negative breast cancer? So maybe Dr. Priya, can you take that question, and then maybe somebody else can opine as well?
Sir, so actually we are using the sequential usage of chemotherapy, that is like the AC 4 cycles followed by 4 cycles or 12 cycles of taxanes based chemotherapy regimen. Now we have 2 set of trials. Once I discussed the 6 cycles of docetaxel and cyclophosphamide based regimen, that the plan B trial which showed that there is not much difference in these two arms, but there is another set of trials, that is the ABC group of trials, which I could not show because of the paucity of time, that actually showed that using three drugs in the sequential manner might be better than using a combination of cyclophosphamide and docetaxel based chemotherapy regimen. We still don't have a trial exclusively focusing on the TNBC patient population along with these endpoints. We do have certain meta-analysis, we do have subset analysis, but we don't have a proper TNBC trial which can actually help us to sort out the answer of this question. But we do have a data now to suggest that yes, we do have a valid option of using docetaxel and cyclophosphamide.
Okay, so Dr. Priya Tiwari says that we can use TC, but the data is not cut and dried, and so therefore her preferred option is still anthracyclines followed by taxanes. And Dr. Nag, what is your opinion? You and I had the privilege of debating this question once.
We
a couple of years ago in Kolkata.
So
and I believe you beat me hands down, and so maybe you can.
You beat me. I was very upset. So
Okay.
I think this was the Tic Tac study where they took years and years to accrue, and what they basically did was try to put forward the TC regimen, the non-anthracycline regimen versus TAC or ACT. And there were three different studies which were combined in this analysis. And if I remember correctly, the only group where the non-anthra was acceptable was the ER positive node negative group, where you could safely do away with the anthracycline. But in all the other subgroup analysis, I think the anthracycline was superior. I don't know, correct me if I'm wrong, that's what I remember.
Yeah, that is absolutely correct. The subgroup where it was found to be non-inferior in that study was the ER positive node negative subgroup, and in other groups, non-inferiority was not proven. But beyond the trials, you know, even if there is a benefit of anthracyclines followed by taxanes, the benefit is not huge. So his question is, and it is a valid question, why has TC not replaced? TC seems simpler. And so why not just do away with anthracyclines followed by taxanes in a good majority of patients, and then reserve it only for a few? Why are all of us so still hooked on to anthracyclines followed by taxanes?
Priya, my question is then, would you give 6 cycles of TC or would you do 4?
If I'm using a combination of like anthracyclines followed by this, then we usually use 4 cycles of each.
No, I'm saying if you did TC instead of AC.
For the TNBC cohort, ma'am?
Yes.
6 cycles. 6 cycles.
Okay, so she would use 6 cycles. So maybe, you know, I think what I'm hearing from Dr. Nag and Dr. Tiwari is that both of them prefer anthracyclines followed by taxanes, given some concerns about the high risk nature of TNBC and TNBC, and possibly TC may not be the default option in such patients. Is that correct, Joydeep and Dr. Walia? Would you agree with that?
Yes. In today's date, I would also prefer AC followed by taxanes in TNBC. TC will not be my first.
Okay. Okay. So Dr. Bharti, the opinion of our panelists is that they would still prefer anthracyclines followed by taxanes. Okay, so Dr. Avinash Pandey had a couple of more good questions. The first one that he had was that, in his opinion, the INFORM phase 2 trial had a single agent cisplatin as the experimental arm, unlike the GEPAR and the CLGB trials, where actually platinum was added to anthracyclines and taxanes or taxanes. Therefore, there were inferior PCR rates in INFORM, and he says that the seniors may add or explain this better. So let me turn to some senior, maybe Dr. Walia. What would you say? He says that, you know, some of the studies that have shown that have failed to prove the benefit of platinum is because you've used platinum as single agent and not as an add-on to the existing treatment.
So I totally agree with this observation. Actually, in this trial, it was only platinum that was used. And doing away with taxanes altogether, you know that taxanes are an important component as far as TNBC is concerned. So that was the main reason, which I also concur. Probably that is why we could find inferior results with platinum alone. The comparative arm was platinum alone. And we have seen in wherever in the NACT setting, platinum plus a taxane is used, the PCR rate has been higher, although albeit at a higher toxicity. So that actually explains that why the results were inferior. So it goes to state that in today's date, probably we cannot do away with taxane, especially in the TNBC. Platinum, with or without, probably in the NACT, platinum may be added, but taxanes we cannot do away with.
Okay, so taxanes cannot be done away with, says Dr. Walia. And, we had one trial in the metastatic setting, the TNT trial, which did show that single agent platinum was equivalent to docetaxel. But of course, there was no combination arm in that trial. So, Dr. Priya Tiwari, what is your opinion about single agent platinum as neoadjuvant treatment in TNBC and the PCR rates?
Sir, actually, as I have shown in the study also, if we are, because there is lot of this talk that the germline BRCA patients have lot of sensitivity towards platinum. So people might think a question can put maybe a single agent cisplatinum in a neoadjuvant setting might suffice. So if you the trial was to answer that question there, that if compared to the previously existing standard of treatment, at that place, maybe the single agent cisplatinum might suffice, but as it has shown that it did not. So maybe the combination chemotherapy are the way to go forward in the case of neoadjuvant setting also, where we are trying not just for a path CR, but ultimately long-term outcomes also in terms of survival.
So Dr. Pandey, more or less the panelists concur with your opinion that single agent platinum is not the best way to treat even in germline BRCA mutated patients, and perhaps that was the reason why it did not improve the outcome. And of course, as an add-on, there are some other studies that have shown that there may be some improvement, although the data is conflicting there as well. So Dr. Pandey has another rather provocative question. So he says, or he asks rather, should we give NACT in operable breast cancer of the triple negative type with the intention to improve PATH-CR in all patients? In other words, how aggressive should we be in achieving PATH-CR in TNBC, provided we agree that PCR rates do correlate with OS benefit in the TNBC cohort? So let me pose that question to Dr. Nag. So Dr. Pandey says that if you have a 1.8 centimeter TNBC, why not aggressively treat with neoadjuvant treatment, try to achieve a PATH-CR and hence improve the long-term outcome? What is your take on that?
So, well, it depends if you believe that PCR is really a strong surrogate for event-free survival. And I don't think, although the Corteza meta-analysis has alluded to that, there are many, many studies which really haven't shown the perfect relationship. So earlier on, what we did was we did aim for PATH-CR in TNBC because what mattered was the residual disease. And if you got a residual disease, then you knew the patient was at a very high risk. So individual patient benefit was seen by adding perhaps capecitabine. But now there is also one that has come in this year saying irrespective of if you use chemo in the neoadjuvant setting, even in the adjuvant setting in high risk TNBC, capecitabine addition may help. So if you believe that and residual disease is a marker of resistance, it can be important to aim for PATH-CR and if not, add extra therapy.
So the question is not of my belief, Dr. Nag, the question is of your belief. So what do you believe? That was his question. Do you think we should give PCR to a patient with 1.8 centimeter tumor or not? And are you doing it in your practice or not? That is the question.
I'm not doing it in my practice because the surgeon snatches the patient away before I can do anything. But I would be thrilled to enroll such a patient in a neoadjuvant program.
Okay, so Dr. Pandey, Dr. Nag says that she would do it if she could, but she has yet been unable to do it because of the surgeons. And I believe Dr. Anupma Mane is here on the panel. I saw some comments from her. So I would urge her not to intimidate Dr. Nag from now onwards and let her do neoadjuvant in relatively small tumors. What about you, Dr. Walia? What is your take on giving neoadjuvant chemotherapy in the quest for achieving PAT-CR in a 1.4 centimeter high-grade TNBC? What is your take on it?
Why did you reduce the tumor size, Sudeep, from 1.8 to 1.4? See, now he's reducing the size.
So less than
Right.
2 centimeter, I will still be referring to my surgeon, even if it is a TNBC. But anything more than 2 centimeter, even if lymph node negative, I would be really tempted to give NSCT. So, I mean, the cutoff which we follow in our institution is 2 centimeter, provided the patient lands up with a medical oncologist.
So, Dr. Pandey, you are, as usual, you are right. Your instincts are correct. The medical oncologists largely concur with you that if they could, they would give neoadjuvant treatment to even smaller TNBCs. And most of them believe that PAT-CR is still something worthwhile to achieve. I have a slightly different opinion, but we'll leave it for another day. Okay, so there is another question from Dr. Atul Narayankar, and he asks which platinum regimen is commonly being prescribed in the TNBC adjuvant setting, and which drugs and how many cycles are to be considered optimal. So Joydeep, which platinum would you use if you do use platinum in somebody? Would it be carboplatin? Would it be cisplatin? And I think we had a similar question about carboplatin or cisplatin. Nobody's asked about oxaliplatin from Dr. Shravan Kumar as well. So which platinum, if you do use platinum, and this is of course in the adjuvant or neoadjuvant setting?
So in the adjuvant setting, I will not be using platinum because there is no clear-cut evidence that it helps. And in the neoadjuvant setting, I will be going with carboplatin if I'm using it in combination with the taxane.
And why not cisplatin?
So cisplatin, firstly, because we have data of carboplatin in the GEPAR-6 as well as the CALGB. So these are relatively large trials. And the cisplatin trial was a phase 2 study with a single agent, and definitely toxicity is a concern for cisplatin.
Okay, very good. So Dr. Joydeep Ghosh says that his preferred platinum is carboplatin. So let me pose that question to the others. Maybe Dr. Tiwari, what is your take? If you do use platinum in somebody, which platinum would it be?
I agree. I tend to agree with Dr. Joydeep. Carboplatinum will remain a choice.
I think the other panelists are also nodding their heads that mostly they will use carboplatin and not cisplatin, and slowly will get out of touch in being able to manage giving cisplatin. The next generation will forget it. So Dr. Narayankar and Dr. Shravan Kumar, carboplatin is the preferred option from most of the panel or all the panelists. And Dr. Avinash Pandey actually also weighed in on this question on the chat box, and he said, like Dr. Joydeep Ghosh, that there was more data with neoadjuvant carboplatin rather than cisplatin, and therefore his option was also carboplatin, which is what everybody else is also saying. Okay, so there is one question from Dr. Richu Sharma, and she asks a clinical question. Suppose she had a patient with metastatic TNBC who had failed first and second line chemotherapy, immunotherapy, capecitabine, and was now not ready for intravenous chemotherapy. Can androgen receptor antagonist treatment be used in such a situation? So this is a relatively precise question about precision oncology. So I'll invite Dr. Nag to come in first, and then perhaps followed by Dr. Tiwari.
So I think the data for androgen receptor is still very, very, it's a little premature. There's mainly phase 2 data that is available. And without knowing the androgen receptor status, I would be hesitant to just off the bat write bicalutamide or enzalutamide, which are the two drugs that have been tried in 2 phase 3 trials with very modest benefits. So it is the luminal type of triple negative, the one that has shown to benefit. Response rates have been 20 to 30%. And you recognize these patients by a protracted course, a relatively a slow nodal breast bone kind of clinical picture, and a lack of response or dramatic response to any cytotoxic therapies. And they generally have an overall better prognosis, but there is no randomized data for the use of androgen receptor blockers yet. But
So
without
suppose
doing
Dr. Sharma's patient,
Huh.
Dr. Sharma's patient had an androgen receptor testing done by IHC, and suppose the receptor expression was 60%, would you then give bicalutamide or enzalutamide?
There is no harm in giving it if patient is refusing any other treatment. So we have used it in patients. We have used it in patients who are strongly AR positive. In fact, Sudeep and I are treating one patient, and I have another patient as well. And we've had a PFS of over a year in both these patients. But this is more anecdotal than the regular thing. I would like my other panelists to also opine.
Okay, Dr. Tiwari, what is your take on treating someone who has failed a couple of lines of treatment, including immunotherapy in the metastatic setting, and has some androgen receptor expression with AR antagonists?
So we are talking about a third line treatment options in a setting of TNBC. By the time you reach third line, you actually become quite desperate. You are looking for all kinds of treatment options available. So depending upon patient condition, I have tried enzalutamide and bicalutamide. There is some data in androgen receptor positive as well. But I am not sure if we have a window of opportunity. That means it might be a slowly acting treatment. It might not give you a treatment option of trying chemotherapy in a next line. So you have to see if it is a slow progressive disease with a minimal metastatic burden, you might try. But yes, I would keep it definitely an option in third line and beyond. Yes, I would.
Okay. Dr. Walia, what is your take on this?
So I definitely agree with rest of the panelists. I have had some experience, single digit number experience, where I have used this androgen antagonist, AR antagonist in this group of patients. What we have to understand is these are a TNBC, post multiple lines, performance status not very well, hardly any options left. And invariably, the patient is now majority of the time not keen on further chemotherapy. So if the AR receptor positivity is there, I do feel that it is whatever worth it is worth giving them a benefit with androgen receptor antagonist. And I've had myself some experience with it. Although it will definitely not be our first choice. It is not a choice. It's generally when a patient perform limited options, poor performance status, we've exhausted other options when we are using these options.
So, Dr. Sharma, most of the panelists opine that it can be used provided there is some degree of AR expression and born more out of desperation of both patients and doctors rather than any real good evidence. But nevertheless, it is still an option. So, there is one very good question from Dr. Atul Narayankar, and he says that, you know, for the BRCA 1 and 2 germline testing, most of the labs are just using NGS and then they don't perform MLPA as a part of their first line testing. So his question: what is the probability of MLPA coming out positive if the routine NGS is negative for any pathogenic mutation, especially if the family history is also not significant, and are we supposed to ask for it in all patients? So let's request Dr. Joydeep Ghosh, do you request MLPA testing in patients who are BRCA1 and 2 negative on the routine NGS? And what is the probability that if you did ask for it, it will turn out positive? And MLP, of course, looks at large genomic rearrangements, which are mostly missed by NGS.
So from our institution, usually we send it to Strand, who actually does an MLPA. So, and honestly, I am not aware if it's NGS negative, how much of them will actually turn out to be MLPA whole gene deletion positive. I'm not aware of any figures.
Okay, so Strand performs an MLP, although my impression was that I have also sent samples to Strand and to other labs, and I agree with Dr. Narayankar that they don't routinely perform the MLP unless you ask for it. Dr. Nag, what is your take? Do you routinely ask for MLPA?
Yes, I always ask for MLPA because I think the studies have shown that you can pick up almost 3 to 5% of cases which you would have otherwise missed. I think that's what the data shows.
So you must have asked for germline test in almost about close to 100 patients by now.
Yeah.
So in how many of them NGS was negative and MLPA was positive?
We picked it up on 2 patients.
2 patients, so 2%.
Yes.
Anybody else has an opinion on this? Any of the other panelists
I have
about
seen in just one
MLPA?
patient.
Or you also do it in all patients, okay?
Just one patient positive, yes, sir.
So I also
One patient
usually
positive.
ask in my patients, but I found only one patient that was germline negative and then MLPA positive.
Okay, so Dr. Narayankar, all the panelists ask for it routinely. I have not asked for it routinely and I don't get it routinely, but I have asked for it when the family history was strongly positive and yet the germline testing was negative. And it is known that about 1 to 1.5% of patients can be MLPA positive when they are negative by NGS. I am yet to find such a patient where this sort of a situation arose, but I think the panelists are saying that it may be best to just ask for it in all patients. Okay, Dr. Jannat Ahmed has a question. What is the role of AKT kinase inhibitor with taxane in the first line metastatic TNBC? So, Dr. Joydeep, what is your take on AKT inhibitors? You did talk about ipatasertib, and there is another study of capivasertib as well.
Yes, sir. The FACTION trial as well as the PACT study, both of them showed an improvement in the PFS with addition of AKT inhibitors. And the phase 3 trials are ongoing. My center, I am one of the PI for the capivasertib versus placebo in phase 3 first line TNBC. So I think once we have the phase 3 data, we'll be more sure about the PFS benefit of this combination.
Okay, so essentially, let me ask Dr. Tiwari, if AKT inhibitors were routinely available to you, would you use them in first line TNBC along with taxanes?
I'm not sure, sir.
You are not sure.
Not sure.
What would help you become sure?
As Dr. Jaideep said, maybe more data.
More data.
Yes.
Any of the other panelists want to talk about AKT inhibitors? Dr. Walia?
No, I don't think in today's state of using it.
Okay. So I think everybody says that although AKT inhibitors have shown some activity, they have not yet arrived. It will take some more doing to make them arrive in triple negative breast cancer. So there is one question from Dr. Gunjan Srivastav, and she's again asking, in patients with metastatic TNBC requiring chemotherapy, is single agent sufficient, or should we use a combination platinum regimen like GEM? So single agent versus combination platinum therapy in metastatic TNBC patients who do require chemotherapy. So let's start with Dr. Nag. What is your take on this?
So generally, if the patient is not in a visceral crisis or there is the symptoms are not too bad, then I'm happy doing a weekly taxane. But if the patient is grossly symptomatic and I need to come in with a quicker response, I would generally prefer a combination, maybe add some platinum to it.
Okay, so single agent taxane in the less symptomatic patients and addition of platinum if you require a rapid response. Anybody else has a take on that, Dr. Joydeep?
Yes, sir. I would agree with Madam. If there is no immediate need of a good response rate, I would rather sequence it rather than giving it together. Doublet.
So what do you use as first line single agent?
So first line, it will be either paclitaxel or nab-paclitaxel.
So suppose the patient has completed their adjuvant taxane about 9 months ago. So what would you use? Single agent nab-paclitaxel?
So in that situation, I would go for either capecitabine or gemcitabine or a gem carbo combination if the patient is having a very high disease burden.
Okay. Dr. Walia?
I'll be more tempted to use platinum combination with taxane in metastatic TNBC. I think there is more data of platinum both in neoadjuvant as well as in the metastatic setting. No data in the adjuvant setting, no convincing data. So if the patient is upfront metastatic, younger patient, a relatively good performance status, I would rather use a platinum combination rather than a single agent therapy. However, if performance status is compromised, then probably yes, I can think of a single agent or a oral capacitor.
I think it is fair to say that there is an equipoise with respect to this question, and some of us prefer to use a combination platinum regimen as a first line. And the reason is that it is rare to see a metastatic TNBC patient, or not rare, but at least uncommon to see a metastatic TNBC patient who's in good performance status, who has relapsed after 9 months, and where you say that you will use a single agent. So many of us would use a combination platinum, the but the other view is also right, that you can sequence, and there is no study that has really shown that performing a combination upfront will improve the outcome over sequencing the drugs. So I think there is equipoise and there is some variation in individual practice. So I think Dr. Sanjay Sharma has a very interesting question. He says that, you all the panelists earlier have commented that they would like to give neoadjuvant chemotherapy in very small tumors. And he says that if the tumor progresses through your treatment, then what happens? Aren't you harming that patient by taking away her chance of being curatively treated with surgery? And let me remind you, on behalf of Dr. Sharma, that surgery alone has cured the large majority of such small node negative patients, even without the use of adjuvant chemotherapy from the old data. And even at that time, TNBC existed, and close to 60-70% of patients would be cured even without any adjuvant treatment also, only with surgery if you have a 1.5 centimeter. So why are you all so gung-ho about giving neoadjuvant chemotherapy even to small genital tumors? So maybe Dr. Nag, you said you would be tempted to do it if your surgeon let you do it. What is your take on? I mean, I'm just asking you to respond to Dr. Sharma.
No, so basically, if the patient is going to progress on chemo and that's a very small percentage, then you can always salvage the tumor is not going to jump from 2 centimeters to 6 centimeters. You're going to keep a watch on what's going on. So your tumor will jump from 2 to 2.5 centimeters, or it won't respond. That's the situation you call in your surgeon. It's not going to become a non-salvageable situation.
So first of all, in my opinion, it is not rare to have a progression. The probability of confirmed overall response to neoadjuvant treatment is only of the order of about 80 to 85%. It's nowhere close to being 98%. And the second thing is that Dr. Sharma says that even though size may become whatever by the end of neoadjuvant, but you've selected out the chemo-resistant clones and you've harmed the patient. So Dr. Tiwari, what is your take on selecting out chemo-resistant clones in about 15% of patients and reducing their chances of survival in your quest to improve the outcome for about 35 or 40%?
Sir, so my take is in majority of these patients, any TNBC more than 0.5 centimeter, we are giving adjuvant chemotherapy with the understanding that TNBC is a systemic disease and there is a lot of chances of micrometastatic disease. If you end up finding that a subset of these patients are progressing during the neoadjuvant, that is going to be the worst patients anyway, to respond to any kind of treatment and to have a good long-term outcome.
Okay. So Dr. Sharma, the medical oncologists say that those who do well because of the medical oncologists, and those who don't do well were anyways destined to not do well. So essentially, they are washing their hands off any responsibility for the patients. And your question has not been directly answered by them. They say that whoever does well, it is their credit, and whoever doesn't do well, it is their destiny. So we'll leave it at that. I don't think there's a good answer to that question. Okay, so Dr. Naveen Kaji Bajracharya has one very good question. A patient with TNBC breast cancer with apocrine features and with high burden nodal disease after neoadjuvant, after surgery and axillary clearance has partial response. besides adjuvant radiotherapy, what else could be done? And what is the prognosis and follow-up of such patients? So TNBC with apocrine features. And let me ask or request Dr. Walia to take that question. She gave a very nice talk on the rare subtypes. And so TNBC with apocrine with nodal burden post neoadjuvant. And of course, the standard would be to do radiotherapy. But what else could you do to improve the outcome?
So whatever we know of this disease, both TNBC, post-neoadjuvant residual disease, as well as the apocrine, they are all bad prognostic markers with not a very good prognosis. And I'll be tempted in such a case, apart from adjuvant RT, also to give adjuvant probably oral capecitabine. Something from the CREATE, probably extrapolating from the CREATE X trial, because we really do not know how many, there was quite a substantial cases which were TNBC in that subgroup. And I'll be tempted to give capecitabine, knowing very well that these patients may still do bad, and we may not be able to alter the prognosis very too much, but still probably capecitabine, if the patient can tolerate, I would like to give.
Okay, any of the other panelists have an option for such a patient? TNBC with apocrine with poor response to neoadjuvant. Capecitabine is an option, Dr. Walia says, and there is of course some evidence for capecitabine in that scenario. Dr. Jadip Ghosh, what is your take? What would you do in such a patient?
So as a routine, I would give adjuvant. I would follow the CREATE-X data for patients TNBC, B apocrine, B no apocrine, who have not achieved apraxia.
So Dr. Joydeep Ghosh believes in CREATE-X and would give capecitabine. Dr. Nag?
Yeah, I would consider some adjuvant capecitabine in this patient.
Not methotrexate and endoxan in low dose?
Metronomic.
Yeah, metronomic with some celecoxib thrown in for good measure. What is your take on that? There is, Priya, I think, showed the IBCSG trial where there was, at least in the node positive TNBCs, there was some separation of the survival curves. Dr. Nag, can you hear us? That question was for you. Oral endoxan and methotrexate instead of capecitabine.
So I haven't seen too many apocrine tumors, but I'm always, if the patient for some reason has too many side effects with capecitabine with the presence of residual disease, I do switch over to metronomic therapy in high-risk patients.
Okay.
So I have
Dr.
specifically in apocrine.
Dr. Tiwari?
I don't have a clear-cut answer to this question. The presence of apocrine component.
Okay, so nobody has a good answer. Yeah, okay. Joydeep, what? Yes, please.
So my question to Madam would be, if you're giving this combination in this adjuvant setting, how long would you like to continue that?
Exactly. So minimum 1 year.
1 year.
I continued for a year, but I monitor them because sometimes they can just come up with bad methotrexate toxicity, even though the dose is small. So you have to keep a close watch. These patients have to come in every couple of months. And it's not very easy to give this. You have to keep a watch.
Okay, so the IBCSG trial also used it for 1 year. So I think we are towards the end of our panel discussion. I'll take the last question from Dr. Anupma Mane, and she is asking, is there any data for adjuvant capecitabine, not post neoadjuvant, as an adjuvant treatment? So there was a FINXX study, and there may have been 1 or 2 other studies. So what is your take on just giving capecitabine? So suppose she's operated on a patient who has 3 lymph nodes positive and triple negative. Would you give capecitabine after your routine anthracyclines and taxanes, or would you not do it? Or even with routine anthracyclines and taxanes? So let's start with Dr. Priya Tiwari. What is your take on adding capecitabine to anthracyclines and taxanes?
Yes, sir, I would.
In high-risk TNBC?
Yes, sir, I would.
You would?
Yes,
okay,
sir.
and how would you sequence it? You use it at the end of anthracyclines and taxanes,
yes,
or what?
Yes, sir. Yes, sir.
Okay.
At the
Dr. Joydeep Ghosh is disagreeing with you, I can see. So what is your take, Joydeep?
The trial mostly included early stage patients and it was a negative study. Adjuvant capecitabine did not improve when they were added to adjuvant standard regimen. So I'm not very convinced about the adjuvant addition after ACT. I'm okay with the no PATCR capecitabine, but not the other way.
But you know, that study was not positive because it was a mixed bag. And you know,
Yes.
the high risk patients, some of those patients, about 60% of them would not have achieved a PATCR. And they are the ones who the Japanese study says, CreateX says would have benefited. So, you know, you are denying 60% of patients some benefit because you say that the overall mixed bag of 100 was negative. That is the counter argument. I'm arguing on behalf of Dr. Tiwari. So what is your take on that?
So I would really like to see the high risk subset, whether they truly benefited with the adjuvant, because the T sizes and the N status was quite low in that side. That is very surprising. That is something that I was really worried about.
Okay. Dr. Walia, what is your take on adjuvant capecitabine?
So in today's state, no, I would not be tempted to use adjuvant capecitabine. I would restrict to anthracycline followed by AC followed by taxane only. I'll not had it been NSCT, then yes, probably with adjuvant, no.
With adjuvant, no. And Dr. Nag, what is your take?
Wasn't there a Korean or Chinese study presented this year that showed a benefit, like a meta-analysis which showed a benefit in the adjuvant setting?
Yeah, Dr. Vinod has just put up a comment on the chat box saying that the Chinese study also showed us benefit,
There
a
was a
DFS
study.
benefit. So now with China, so are we closer to Chinese and Japanese or to the Western population? That is the question. Where does your heart lie, Dr. Nag? East or West?
My heart lies in India, but CreateX was also a Korean study, if I'm not mistaken, right?
No, Japanese.
Japanese, yeah. So, and we are following it.
So Chinese, so that adds, so Chinese data adds to the Japanese one. So we should give adjuvant capecitabine. So are you doing adjuvant capecitabine in high risk TNBC or no? As Dr. Anupma Man is suggesting to you.
So I'm doing it for node positive patients with large tumors, triple negative.
Okay, so I think we will close the panel discussion on this point with some bit of disagreement and a valid disagreement between the panelists, because you know there is no one cut and dried explanation or evidence on this question. Some of them use adjuvant capecitabine in high risk patients, others don't, and I'm sure both do it for good reasons. So I think with that, we come to the end of the panel discussion, and I would like to thank the learned panelists and the organizers for giving the audience and myself the opportunity to benefit from their wisdom. And I hand the screen back to the organizers. Thank you very much.
Thank you so much, sir. With this, we will end up this session. Dr. Nag, would you like to conclude it?
So I think it was a great session, and thank you all for joining us. We had a great time. Thank you, Lupin. Thank you, Riverroot, for arranging it. Thank you to all the panelists and Dr. Sudeep for moderating. And we had some fantastic questions, and I think this is still a hot topic for debate. Thank you.
And
Thank you, everybody.
With this, the webinar is over. I would like to thank all the faculties for their wonderful discussion, to all the participants for their valuable time, and would like to thank Lupin for their support. Thank you so much.